Welcome everyone to All Health All the Time. I'm happy to talk to you today about discogenic back pain and other kinds of back pain. And today we have my colleague, Dr. Jose Mena, with us to help us understand this complex subject. Dr. Mena, let's just dive straight in. What is discogenic back pain?
Discogenic back pain, as the name implies, it means that the back pain is stemming out from the disc, which, as we know, is the most common source of back problem. Basically, the studies they range anywhere between 39 to about 41, 42% of the population. They suffer from when they are having an episode of back pain from this disorder. So it's a very, very common thing that we encounter every day in our practice, and I will assume that in your practice as well.
Now, is this a normal part of aging, or is this a true disorder?
The disc itself will start degenerating over time. Normally, we get some fissures in the disc. We start losing some water content that will attract the molecules, and they will keep the strength of the disc. So we start losing the water, the molecules. They start not binding properly, and that's when fissures and tears they occur within the disc, and the whole process or cascade will start occurring, and that will lead in eventually into having the usual signs and symptoms of back pain.
Dr. Mena, correct me if I'm wrong. Let's say you have an elderly patient. What is the chance that on an MRI you will see some evidence of discogenic change or degenerative disc disease?
Quite high, and actually it's close to nothing in medicine is 100%, but it's quite high, and it's over 90%, nearly 100%. So it's basically that's a universal sign of degeneration, or like having a gray hair there on the spine. So it's very quite common, and it's something that we'll see on MRIs. And as you know, basically because you have this degeneration doesn't stand or doesn't mean that you have to have back problem itself. And actually it's being considered a misnomer of degenerative disc disease when in true it's actually an internal disc disruption syndrome, what causes the back pain itself.
Makes sense. So then if you have a patient who has multi-level degenerative discs, how do you figure out which exact disc is the cause of this patient's pain?
Very, very good question. At least basically a lot has to be by history, exam, and also prevalence. So we know that the last level, L5S1, is the most common one. So if the pain is very low and we are having back pain down in the waistline area, the chances are that the L5S1 or perhaps the L45, the level above, the segment above, might be the source of problem. But normally we go mainly by prevalence and the patient's history and physical findings as well.
So let's say in your experience, you make the diagnosis and it's discogenic back pain, and the patient goes through the series of injections and physical therapy, and they come back and they're still suffering. In your experience, what tends to make the patients better? Is it decompressions or is it fusions?
Traditionally, when someone has back pain, and actually you can chime in better than myself in here, but traditionally, basically, the decompression is basically when you have a nerve compression, you want to decompress or take the pressure away from that nerve. So in entity, decompression is not help someone with a back disorder. So traditionally, throughout many, many years, the fusion has been the standard of care for this type of problem. And as you know, there's multiple type of approaches for fusion. But normally, fusions, they carry the risk of what we call an adjacent segment disorder. So maybe the level above or perhaps the level below, where you're doing a fusion, can degenerate at a faster rate, and it can lead into having in about 15, 16% of patients in a 5-year mark, an adjacent level surgery, and a 10-year mark, about 36% of the patients. So kind of increases the risk of developing another surgery down the road. So that's the reasoning of why something can be done, and that's when we are leading into this newer technology that we know is being approved as of now in the United States for the cervical spine, but also it's very intriguing into the lumbar spine.
So you've talked about surgery, the most aggressive treatment. Now let's reverse and talk about injections. When should patients consider epidural steroid injections?
Well, we consider the epidural injection, and let's start even before that. Typically, someone who has a back disorder, the vast majority of the patient, or 90% of the patients, they're going to get better purely with an exercise program. Not only going to physical therapy, they're going to get better eventually over time by doing those exercises. So if someone is not getting any improvement, they are still having issues, they're not progressing well, that will be the indication for an epidural steroid injection. Normally, when we do an epidural steroid injection, what we're putting is there's multiple ways of doing it, but traditionally, the way that a lot of us, including myself, we favor will be the transforaminal approach, because we're putting the medication very close to the disc area. So we put in what we call the disc nerve interface. So we're putting the medication, we're delivering the medication very close to the structure, and also we're putting local anesthetics, which will help us out eventually, immediately following the procedure. If the patient gets relief, we can actually have a better idea and understanding that that's where this problem or the source of pain might be coming up from.
Makes sense. Dr. Mena, kind of a one question specifically about different types of epidural steroid injections. It's not uncommon for me to hear a young mom say that her pain began ever since she had that one epidural that was done in order to ease the pains of childbirth.
I get that as well. There's no evidence behind that. Honestly, the chances are extremely low that you're injuring some structure there. Because normally, that type of injection is done from the back. So you put the needle, you have to transverse certain structures in order to go through we'll call it thecal sac. That's where eventually nerve roots you're going to get them. So the answer is it's no, very unlikely. That's not going to be the source of having an injection is causative, or it's going to be the source of your back problem just immediately following the epidural injection after labor and delivery.
Makes sense. And circling back to the normal progression of conservative to more and more aggressive care, when do you, as an experienced practitioner, start to think about getting a surgical consultation?
Good question. Normally, we start getting that conversation when we're seeing that we have done A, B, and C's, right? So we have done the physical therapy, the patient's still having issues. We're doing the injection, and the patient either A, they don't get long-term relief, meaning you can get 2 or 3 months and you're a very active patient and you're not getting that amount of success from the injection, or you got the injection and relief immediately following the procedure, but at the 2 or 3 week mark, you're still having issues. Normally, those will be good, suitable candidates for surgical consultation, as far as there's evidence on an MRI or imaging study that the disc, in this case, we're looking at the disc, there's a disc disorder that might be the source of problem. So those are the patients that we consider that are surgical candidates. We also see on MRI some findings that are very likely that will increase the chances of having that the disc is the source of problem. And one of them we'll see seeing a small dot in the disc, a white dot in the disc. That's what we call a high intensity zone or annular tear. And the other thing will be some like a halo around the disc. That's what we call the modic changes. That's very likely. We have an inflammatory marker we call modic type 1. That's very, very likely that might be the source of the problem. And those patients eventually, the signs and the possibility of the disc being the number one cause of problem is quite high.
It makes a lot of sense, Dr. Thank you for your great explanation.
Thank you so much for having me here.